For those amongst you that have read the title of what I'm supposedly talking about, this is different, and that's probably, I just have to let you know now that I feel that I'm a rebel, and that's why. Actually, it's part because Catherine and I had a conversation about what she was going to talk about. Now, I did my Master's and PhD in idiopathic orthostatic hypotension in the elderly, so I had to filter out patients because of the medications they were on. So it's actually quite fitting that I'm following on when someone is talking about what I would term physician-assistant postural hypotension. You can use that term, I haven't got a copyright on it. So what I am going to talk about is around rationality of choice. So I'm really keen to talk about human factors and patient safety, and so that's what I'm going to talk about. I'm going to talk about psychology, about how we behave as humans. So I'm going to talk around the perceptions that we have about medication safety, about how we balance uncertainty with risks and benefits. These are normal human behaviours. And I'm then going to talk about and explore what are our normal responses to uncertainty. How do we normally behave? And then at the end, I'm just going to flip it and just sort of think about what can we do to change these things. The Health Quality Safety Commission has established itself as alerting us to the problems that there are with medications, and it tells us about medication safety, and it's very informative information. It tells us how many people are going to be harmed, what's the likelihood of them being harmed, what are the factors that are actually going to enhance that harming of patients, and what it's costing us. It's very, very useful information, and what they'll tell us about what are the high-risk medicines. The question is it the medicine's fault? Is it something to do with prescribing the medicines? That's a really key one. And although we can talk about the complex pharmacology of these medicines, when we look at the actual amount of drug errors that occur, and in hospital setting, we know that a bulk of them are due to the prescribing of medicines and to the administration of medicines. Very few of them are due to the dispensing of medicines. So there are some really important issues. Now, one of the things that you'll notice is that the logo for the Commission is the Swiss cheese model, and this is about how errors occur. And we know that errors can occur quite easily in terms of medicines. So when we think about dispensing errors, when we have the look-alike drugs, or the sound-alike drugs, it's not a surprise. In fact, I'd be surprised that there weren't more of these errors. When we just walk into a pharmacy and you find that there's a uniform presentation of medicines. And currently I'm doing some research with psychologists looking at anaesthetists and looking at how they can distinguish between look-alike drugs. We have sound-alike drugs. The issue here is this is really hard stuff to solve. There isn't really any ownership of what this problem is. When we talk to MedSafe, when we talk to Pharmac, when you talk to the suppliers, they don't want to know. It's not their issue. They're going to tell people that you have to read the label. It's not going to happen. Because we know that when errors occur, it's because there are these errors that occur. And this is Jim Reason's model. It's a Swiss cheese model of error, that we have this trajectory that goes through these barriers like holes in Swiss cheese. Lined up, they won't intercept these errors, and something bad happens. And it makes a lot of sense. The aviation industry and the other high reliability industries have used this for quite some time to look at the problem. What's really interesting me is what's behind this? How does this originate? What's the origin? What is the cause of this? So, what I'm going to do is talk to you a little bit about where we see medication errors. Now, this is Geoffrey Aronson. I'm sure you're familiar with his work from Oxford, where he's looked at medication errors, and we've created definitions. So if we define the problem, we can actually make the problem go away. We can say, if we define what a medication is, an error is, what a medication error is, what a prescribing fault is, what prescription errors are, and then we can also add in balanced prescribing. So, we've got these terms. what a medication is, what an error is. What a medication error is. What's really interesting here is they're already starting to talk about, in terms of medication error, being that leads to harm to the patient. And also, harm also implies lack of benefit. We know that we've got other definitions around prescribing faults. This is a rational prescribing. So this is around inappropriate or under-prescribing, over-prescribing. So these can relate to errors. And then we've got these prescribing errors, and we have a very clear indication of what these can look like. Balanced prescribing, though, comes into this really interesting term now, where what I'm really keen to talk about. We're now starting to talk about uncertainty, and Catherine's talked about this. We're now talking about this balance of benefit and harm, and it excludes prescribing faults. So I was curious about this. What does this actually mean? What do we mean when we talk about these things? So when we go and have a look at how we see how drugs are being prescribed and where we get these interactions occurring. So this is Bruce Guthrie's work from Dundee. He looked at over 300,000 patients in 1995 and again in 2010, and looked at the change of polypharmacy. And it's maybe difficult for you to see. This is age groups of patients. This is the percentage of them. And this is having no drugs through to having 15 or more drugs. And this is 80 years or plus. Given the fact that half of us are going to be living over 80 years of age, this is quite disturbing. Now, this scale here isn't up to 100%, it's up to 50%, but again, they looked at serious and potential serious interactions between the medications that these patients had. And they found that a significant number have at least 1, 2, 3, or possibly 4 or more interactions that are occurring. Their conclusion is really interesting because they talk about the need for polypharmacy. It's a necessary evil in some ways. It's important to get the right kind of outcomes. And I worked closely with anaesthetists for a long, long period of time. These people, polypharmacy is their bread and butter. That's their core business. They know about interactions. That's what they do. In the same way that you guys know about interactions as well. It's potentially problematic because it's not always inappropriate. And again, we're getting these terms occurring here that it does not always cause harm, but it may be a price for the benefits. So we've got harm, benefit. And again, as Catherine said, there's evidence on healthy young people, but not old people on multiple drugs with polymorbidities. So, this is really interesting stuff to me because I start to think then about what do we know about benefit, harm, and uncertainty. How do we make decisions around benefits and harms? And how can we be sure of what the outcome is going to be? This isn't just limited in healthcare to prescribing. This is also some other areas. So Tammy Hoffman and Chris Del Mar from Bond University in Queensland published earlier again this year a study where they looked at how they did a systematic review of papers. They found 36 papers where participants, these are patients, described how they perceived the risks and benefits from treatment, tests and screening. And they said that the public really had an accurate expectation of benefits and harms. And for many of these interventions, they had a tendency to overestimate benefits, a tendency to underestimate harm. Which is really interesting, because that's right at the beginning of their discussion. Buried within their discussion, they say that, hang on, there are several other studies that have actually point out that, in fact, this is what clinicians themselves believe as well. So patients and clinicians are actually no different when it comes to perception of risk, harm, benefit, and uncertainty. So this has some really interesting implications, because I was thinking this must be a normal human behaviour. So other areas of risk, harm, benefits and uncertainty surely has to be economics and the stock market. So I'll talk a little bit about uncertainty. This is a guy you should read. Check him out on TED. He won the Nobel Prize in 2003 for economics. He's a psychologist. This book that he's written, Thinking Fast and Slow, is extraordinarily good. Read it. It's just summer holiday reading, I'd say. It'd be worthwhile looking at. So he started doing a lot of work with his colleague Amos Tversky, and they started looking at certainty and uncertainty. And so the principle of certainty is around, if you're sure about something, you're more likely to take it. But if you're unsure about something, you might take a few more risks. So we've got two choices here. One is, would you prefer a 50% chance of a 3-week holiday in England, France and Italy, or a 100% certain chance of a 1-week tour of England? The other choice you've got is a 5% chance to win a 3-week tour of England, France and Italy, or a 10% chance. So what they found was that a majority of people will pick B over A. So they will pick something that's certain over something that's uncertain. When they have a chance of uncertainty, they will actually pick something that potentially has greater rewards. Does that make sense? So this actually starts to open up some issues around how we make decisions around uncertain things. So in this book, and in other papers as well written by Kahneman, he talks about how we go through making these choices. He talks about system one. This is this complex judgment and how we come to complex judgments and preferences quickly. This is heuristics. We do this effortlessly. We try to do it the simplest and most easy way we can. We don't want to overload our mind. We call this intuition. He calls it pattern recognition. We also have system 2, which is about computing the judgments, and it's basically going back to basics. So the way it works is this. Basically, an intuitive judgment is initiated, and then we will go back to system 2 to, is it right? We can adjust it. We can correct it for biases and make sure it isn't violating any rule. If it doesn't work out in our own mind, then we'll go to system 2 and compute it. Okay. So for you to experience this, it's quite important to think about this. This is a simple test. Don't think too closely about it. You can think closely about this. So a bat and a ball cost $1.10. The bat costs $1 more than the ball, so how much does the ball cost? So I'll give you a little while to think about that. Okay, it's a trick. Anyway, so the number that most likely comes to mind is 10 cents. Would that make sense? Yeah. It's intuitive, it's appealing, and it's wrong. Because we see the pattern of $1.10, $1, 10 cents, $1, my dollar's 10. Yeah, that'll do. The correct answer is 5 cents. Okay, I thought I'd better tell you that because those of you that thought, hang on, it's got to be 5 cents. You go, yeah, because you're handsome, beautiful, intelligent people. So, if we look at more uncertainty, it can also be how things are framed. So, I'm going to give you 2 problems. So this one is that you've decided to see a play. The admission is $10. You've gone to the theatre with $20 in your pocket, but when you get there, you've discovered you've only got $10 left. You've lost $10. Would you still use your final $10 to see the play? So you can think about that, and what they found is 88% of people will go yes. 12% of people will go no. Make sense? Yeah, of course it do. Right. Imagine that you've decided to see a play and you've already paid the $10 for your ticket. Okay, so you set off with your ticket and your $10 and you lose your ticket on the way. Because you've lost your ticket, they can't give you another one. The question is, will you pay another $10 to see this ticket, to see this play? 46% go no. 46% go yes, 54% will go no. Now, in terms of the odds, you started off with $20, you've seen the play, you've got no money. But our ability to accept this is altered by the way we frame these things. So what comes out of this is that we actually make decisions not on some logical, statistical process or mathematical process, it's actually more to it than that. So what came out of it was this concept of prospect theory. And I won't dwell on this too long, but the issue is that it shows the same thing. What will happen here is that we will accept gains that are greater, but we will actually reject losses that are smaller. So sometimes when it comes down to money, to gambling, we will make unequal assessments about gain and loss. It's not a linear process. How does this fit into what you guys do? Now, this is a really interesting one, and you have to bear with me, and I won't overly explain this one. So that's basically what these curves mean. So these are some very, very talented Polish people. These are psychologists with a deep understanding of mathematics. These are the people, remember the Poles were the people who came up with the Enigma machine before there were computers. These are really smart people. What they did is they gave people the similar kind of financial gain-loss process, where the gains and losses were different. What they did, though, is they gave people a certain loss with an uncertain gain. They also gave them a certain gain with an uncertain loss. So what they're saying here is we're going to give you 900 or 9,000 Polish zloty, which for those of you who aren't sure of the exchange rate, a zloty buys you 39 cents New Zealand. So this is about $360 and $3,500. And they then said, so this is your certain gain. We will give you that. Will you accept this if there is a 95%, 70%, 30%, or a 5% probability that you will have an associated loss with that? Now, that loss went from 1 zloty to 9,000 zloty. So you could lose some of it or all of it. Does that make sense? So my analogy here is we're going to give you hormone replacement therapy because it will make you feel better. There is some evidence that you may have a stroke. That's your loss. Does that make sense? So what we see here again is this asymmetry occurring. We see that, in fact, people will accept this they will only accept this if there's a 60% gain, but if you deal it the other way, people will accept it with only a 10% gain. So this is a fascinating area about how we accept and reject these things, and what does it actually mean? I'll have to say that at this stage I'm uncertain, and I'm quite happy with my uncertainty about this. I think it's actually a very, very curious area and something well worth researching, and I think that we could be onto something here. What we do know is this. When we're testing this for money, if we're doing this where there's financial stakes, we accept gain and reject losses with different values. We see the same kind of patterns occurring. They may be different, but we see this happening in clinical care. So it may be important in the way in which decisions are affected by the framing of outcomes and how that's communicated. So, are you familiar with this? Has anyone seen this image before? Yeah? No? Oh, good. At least one person. Right. So this is really interesting. It reminds me, I think Martin Tattersall in Sydney has done some work around the 3 questions patients should ask their doctors. And this is around, what are my options? What are the risks and benefits? What is the likelihood? And so we have this here. And so this is really important. And I was sort of thinking about how could a system like this work? And what are the drivers for safety in healthcare that we've seen? So in healthcare, and this has been a really interesting development, has been the surgical checklist. So that there was a time when the surgeon was God, he came in, the reason why everybody else was in the operating theatre was because of her or him. And now we have this situation where the surgeon is expected to be there with everybody else, and we go through a surgical checklist where everything is read out, where people introduce themselves by name. It's a change in culture. It's brought around a huge amount of change in terms of improving safety. It's probably not so much through checking things, it's probably about empowering people to speak up. So I'm really curious to see how this can actually happen. Oh, this has got flipped around. Oh, that's what happens when you change computers, eh? Could there be a polypharmacy checklist? Could something like this happen? This isn't for the patients to ask you, it's for you to ask yourself. So, what are all the options for including the elimination of medicines? What are all the benefits and risks of all possible options? And this is really quite important. How likely are these to happen given inherent uncertainties? And I may overestimate the benefits and underestimate the risks. So I'll leave you with that.